Hi everyone, and welcome to this afternoon to another Lymphoma Australia patient educational webinar. My name's Emma. I'm one of the nurses at Lymphoma Australia, and I'm based in Victoria, and I'll be your host for the webinar this afternoon. I'd like to start by acknowledging the traditional owners of the land and like to pay my respects to elders past, present, and emerging. I'll start with some quick housekeeping. If you have any questions throughout the webinar, please put them in the Q&A function at the bottom of the screen, and we'll have some time at the end to answer some of your questions. There is also a chat function, but this won't be monitored for questions, so please use the Q&A section if you do have any questions. And you can post them throughout the webinar, and they'll be answered at the end of the education session. If you do miss anything today, please don't worry. The webinar is being recorded and will be uploaded to our YouTube channel and Spotify within the next week. And also a link will be emailed directly to you as well. There was a pre-education survey link that was sent out this week with the Zoom link, and thank you to all of who have completed that. We really appreciate it. I have put the link to the survey in the chat, so if you haven't had a chance to complete the survey, you can do so now. It should only take you a couple of minutes. There will be an additional post-webinar survey that will be sent out in the coming weeks, and we would really appreciate your feedback. And this just helps us to ensure we're delivering high standard webinars that meet the needs around your education and support. We've been building our webinars for this year, and we have quite a few planned in the coming months. We have a Hodgkin's lymphoma webinar in July, and then a 3-part mini-series on supporting families, covering the topics of working in lymphoma, supporting the partner and carer, and talking to your children and young people about lymphoma. If there are any specific education topics you would like us to cover in the future, please don't hesitate to reach out. We're always open to new ideas, and we want to cover topics that are relevant and useful for you. For anyone who isn't aware, we do hold regular support groups, both online and in person, and all of our upcoming groups can be found on the events calendar on our website. The next one will be for patients in remission, being held online on Wednesday, the 12th of July, and an in-person support group being held in Melbourne on the 28th of July. I will also put a link to our events calendar in the chat where you can find all the dates for our upcoming support groups and webinars, and you can register for the ones that you're interested in attending. Okay, now on to today's webinar on the topic of cytogenetics in CLL, presented by Dr. Sasanka Handunnetti. So Dr. Sasanka has expertise in chronic lymphocytic leukemia and indolent lymphoma biology and therapeutics. She's a haematologist at the Princess Alexandra Hospital in Brisbane and recently completed a tenure as a haematologist at the Peter MacCallum Cancer Centre in Melbourne. Dr. Handunnetti is currently completing a PhD evaluating novel therapeutic combinations in low-grade B-cell non-Hodgkin's lymphoma and chronic lymphocytic leukemia. Thank you so much for being here today with us, Sasanka.
Thanks, Emma. Just share my screen and you can tell me if everything's looking okay. How does that look to you, Emma? Can you see my first slide?
Yes, all good. Can see it.
Hi, everyone. Thank you for making time on a beautiful Saturday afternoon to learn about cytogenetics and molecular testing in CLL and SLL. My name's Sasanka. I'm a haematologist with significant interest in the management of both of these conditions. I have to say up front that I'm no longer a practicing haematopathologist, and therefore my expertise in cytogenetics and molecular comes from the clinical interpretation rather than in the analysis, where far more well-equipped colleagues are at the coalface every day, interpreting these sometimes complex tests and giving me guidance on how to interpret them. So with that, thank Emma for the kind introduction, and let's get started. So what is cytogenetics? It's a big word that really just refers to the study of chromosomes. Chromosomes are long strands of DNA and protein that contain all of our human genetic information in every cell of our body, excluding red cells, which don't contain a nucleus. Cytogenetics involves testing of tissue, blood, bone marrow, in the lab to look for structural changes in these chromosomes, these long helical strands of DNA, where you look for components that may be broken, that may be missing entirely, that may be switched around, rearranged, or where you may have additional chromosomal material. Today, what I will be specifically focusing on is the chromosomal and molecular changes that happen within your CLL cells alone, not in the cells of the rest of your body. So a little bit more about chromosomes. So what are they? Here's a pictorial example that I took from the Lymphoma Australia webpage. You can see there's a cell. Within that cell, there's a central component called the nucleus. This, if you like, is the factory that tells our cells how to behave, what to make, signals to respond to, and that's in health. In disease, you can have problems that occur within this nucleus and within these chromosomes, this genetic material that doesn't just say how to work, but how to misbehave, how to grow, where these cells should be dying, how to proliferate and hide in places where growth should not occur. And so really this speaks about how CLL can occur in people. When we look further into this nucleus, we can see these chromosomes here, where you can see these intertwined long strands of DNA that contain our entire genetic material. And this DNA is the genetic material that tells our bodies what to do and when. So really crucial, and in every cell of our bodies, except for our red blood cells. Every human has 23 pairs of these chromosomes, and these are divided into a short arm or a P arm and a long arm called a Q arm. And these are all made up of strands of interconnected DNA, the building blocks of our bodies. These DNA tell our bodies then how to regulate certain genes, how to produce certain proteins, how to respond to signals within our bodies. And in CLL and SLL, we are looking for the structural and molecular changes that occur that can trigger a healthy, normal, mature B cell to become an abnormal cell that becomes CLL and then goes on to cause disease in humans. So here's an example of the chromosomes that are seen in a normal female. So you've got your, these have been analyzed with specialized staining and under a microscope, where a scientist has actually looked at every single chromosome in this person's nucleus and laid them out. They are often a mishmash under the microscope, but these scientists and pathologists who interpret these can visually recognize by looking at the length and the banding which chromosome is which. So they've laid them out here to make them easy for us to look at. You can see that we've got 22 pairs of symmetrical chromosomes. And then the last chromosomes at the bottom right are the sex chromosomes. So in a woman, you'll have XX and no Y material. To give you an example of...
Sorry to interrupt, Sasanka. I think we can see your notes as well.
Okay.
I think you're in presenter mode. Sorry, I thought that we could only see that, but
okay.
I think...
Give me a sec and we'll share a different screen. Apologies, everyone.
Apologies.
All right. I'll just stop this share.
Yes, that's perfect. Sorry about that, everyone. Sorry, Sasanka.
No, pardon me. Okay, let's get back in. All right, still on the right view?
Yes, just the slide now. Perfect. Thank you.
So let's move on to a normal male carrier type. And so this is someone who is 46XY, so 23 pairs and your sex chromosomes. And these are, again, laid out here for us to easily recognize. 22 identical pairs, then one X and one Y chromosome, which defines a male chromosomal set. So why are chromosomes important in CLL, SLL? Well, they're very common to have abnormalities in our chromosomes in CLL, SLL, and changes that can be acquired over time, causing CLL, can be the process by which CLL cells acquire damage that allow these healthy immune cells to become CLL cells with abnormal growth rather than death when they finish their normal immune function, and spread to sites to form enlarged glands, to form extensive bone marrow and peripheral blood involvement. And we used to think of cancer as a problem that occurs in one cell that goes rogue and creates multiple abnormal cancer cells. Now we know that it's single or multiple normal cells that can cause multiple clones. And in CLL, that's true as well, where there's often a dominant clone marked by certain genetic or chromosomal changes, but there'll be other chromosomal, other clones in the background that have slightly different chromosomal or genetic abnormalities. And this can be important over time because our cancer cells are constantly trying to find a way to overcome the control of therapy and to become resistant and to survive. I'll talk about what dominant clones and subclones mean when we talk more about clonal evolution. So there are three main changes to our chromosomes that can occur. Deletions. So you can see in the orange cartoon here where the long arm of this chromosome has actually been taken away. Translocations can occur, and that you can see in the far right, where there's been a switch between two different chromosomes of material, and these can be balanced and unbalanced. Balanced means that equal components have switched between the two. Unbalanced means that sometimes there's been an unsymmetric swap in that genetic material. Mutations can also occur, and this can often mean that you have extra genetic material either as an add-on or as a standalone. I'm going to talk about different examples in CLL that we see frequently. At the end of this talk, we'll be talking briefly about molecular testing and mutations and the implications they have there. So how is cytogenetic testing performed before we go into examples of what happens in your CLL? We can evaluate three common tissue types. Your blood, sampled as an ordinary blood test from your arm, done at any pathology centre. Lymph nodes, where it's best done on fresh tissue, and bone marrow aspirate or bone marrow liquid that can be taken at very selective times in your treatment journey. With CLL, because this is a disease that's circulating by definition, it's running through your veins. The easiest way that we can test cytogenetics and molecular is in your blood, because the disease is sitting there in your bloodstream, and we don't need many cells really to be able to get a good result. If you have small lymphocytic lymphoma, you may not have much happening in your peripheral blood, so your clinician may evaluate your disease in your bone marrow or in a lymph node, and there's no disadvantage in having this done, apart from this being a more invasive test. So I'll talk first about conventional cytogenetics, which were the first two images of the male and female chromosomes that I put up. This is an example where in figure A, we've done a blood draw, and that tube is sent away to a specialist laboratory. Those cells are, in figure C, cultured in a tube. CLL cells 50, 60 years ago used to be notoriously difficult to culture and grow, but we have gotten better at that. And what we'd like to do is grow up these cells so that they're enough to evaluate, and then they're stained and put out onto a microscope where we aim to look at the chromosomes with a minimum of about 20 CLL cells under the microscope, where you can see an E. There's not the nice spread of chromosomes that we saw in the previous figures. They're all lumped together, as you'd see in a normal human cell, but these are actually teased out and then mapped into the 23 pairs plus the sex chromosomes to see, to look for, under the microscope, apparent structural changes, as we spoke about, deletions, translocations, mutations being the most common. Cytogenetics is quite complex. So in each of your states, there may be one or two qualified pathologists who look at these samples day in, day out with their scientists. And the key thing to remember is that when we look at all of these reports, the pathologist will have a concluding remark that draws clinical relevance to these tests, which can be very, very difficult to interpret, even if you're a CLL doctor. The next modality of testing that is commonly used to evaluate chromosomal changes is something called fluorescence in situ hybridization, or FISH testing. This is really a complement to conventional cytogenetics. There can be structural changes that are not detected ever by FISH unless you get that specific test done. And conversely, there can be minute changes in your chromosomes that are too small to really detect using that gross microscopic analysis of structural change. So I see these two tests really as going hand in hand. And in my practice, I always like to see both of these results for patients rather than trusting cytogenetics alone or FISH alone. FISH is a targeted panel of testing that can get to very specific point mutations and deletions. Most panels across the country will involve looking for the most common and informative mutations that occur in CLL, in particular, changes to your chromosome 13 in your CLL cells, changes to your chromosome 11, changes to your chromosome 17, and changes to your chromosome 12. It is very important, but not necessarily always done in each state, to evaluate for a translocation, a switch of chromosomal material between chromosomes 11 and 14, because even though this doesn't define CLL, it defines 99.9% of mantle cell lymphoma, which can be an important mimic. And this can be one of several tests that can be very important at your diagnosis to distinguish which of these diseases you have, because the treatment paradigm for these diseases and the long-term outcomes are vastly different. I'll take you through this schema of what is FISH. So FISH testing uses targeted probes. Unless you've got a probe looking for an abnormality, you're not going to find one. And the way this test works is you pick a panel with these probes, and these have a fluorescence label on them. You then add that to the patient target DNA, which you unravel to open these paired strands to allow for binding to occur between the fluorescent probes and the patient's DNA. And at these particular target sites, you can see binding or lack of, if there's a lack of genetic material at that site. And you look for red dots to demonstrate fluorescence as positivity. You look for extra signals, you look for a suboptimal number of signals to be informative about duplications, extra genetic material, or deletions at these points. And this is an example of looking for deletion P, which can be done in a really sensitive way. And what sensitivity means is that we can find if it's negative, if FISH is negative for deletion 17p, you can be confident that your CLL doesn't harbor this mutation. I'll talk more about what 17p means, but it can be critical in predicting resistance to chemotherapy, which hopefully, as of this year, is a thing of the past for all of you. And can also predict suboptimal responses even to novel therapies, although not as bad as how it predicted outcome in the chemotherapy era. So if we look at the figure first on the left-hand side, you can see that in each cell, there's a single red probe, and you would expect two, one on each chromosome, which tells us, okay, there's been a deletion. There's a deletion 17p detected in each of these CLL cells. On the other hand, in this image, each of these CLL cells has 2 red probes. So again, our scientists would count about 200 CLL cells. And the beauty of FISH is that targeted panel, highly sensitive test, where if you're negative, you can be confident that's a true result. And it's a quick turnaround in the order of a couple of days, as opposed to cytogenetics, which takes much longer. The third testing modality I wanted to speak to you about, which is gaining traction worldwide and in Australia, is called Microarray. And this is a molecular test that can be a good substitute to look for chromosomal changes in your CLL cells. What this requires is DNA rather than the need to obtain many cells, grow them in cell culture. So it can be technically and logistically easier, but potentially more prone to error in that you need to see quite large abnormalities in your genetic material to detect chromosomal abnormalities, as opposed to the very specific point mutations that can be detected using FISH. Again, this is not a standalone test, but something that can be used in a complement, evaluating both your karyotype using the most conventional methods and FISH together. The most common type of microarray used is called single nucleotide polymorphism microarray. And this can be better than the earlier iterations of microarray because it can detect more changes compared to comparative genomic hybridization. So we use very minimal genetic material from your CLL cells to look for gains of material, loss of material that correlates with those chromosomal changes. So this is an example in a patient of a loss of 11q. This is the gene that has to do with the ATM gene mutation, the chromosome that has to do with the ATM gene mutation. So you can, and this is called mosaic. Mosaic is a bit of a technical term that means that some of your CLL cells have this change and others don't. If you imagine the tiles of a mosaic where everything's a little bit different. So in this cell, you've got 2 copies, and here you've only got 1, and that reflects an 11q that you might see through other modalities. Smaller things like a very low burden of deletion 13q or a deletion 17p may actually go undetected using this modality because they can be very small changes. So it's really important to consider together with your clinician whether the other modalities need evaluation as well to really give you a complete answer about the flavor of your CLL. So what are the common cytogenetic abnormalities in CLL? The important thing to note is not all CLL is equal. You would all know very well that there is some CLL that is very quiescent for a long period of time. There will be people who never need treatment in their lifetime, and others who have disease that behaves quite aggressively, that is highly refractory to treatment and limits their survival significantly. And chromosomal and molecular testing, the purpose of this is primarily to tease out those different diseases at their outset, and also to look at how this evolves through your treatment journey so that we can predict outcomes for you, so we can select and guide you towards the best therapies. So 80% of people with a new CLL diagnosis will have an acquired chromosomal abnormality in their CLL cells. This has nothing to do with hereditary mutations. So these are just things that have occurred over time, nothing that you were born with or that you were handed down from your parents or that you have risk of passing on to your children. So what are these mutations? Deletion 13q is the most common, occurring in more than half of patients, and this actually predicts for a favorable prognosis. People commonly have many years in an indolent phase where they're in watch and wait before anything occurs that might meet criteria where treatment needs to be initiated, and often response to treatment is highly favorable. Deletion 11q is the chromosomal loss associated with mutations in the ATM gene, which is important in cell signaling in CLL. And this occurs in about 1 in 5 people, and it confers an adverse prognosis. Arguably less so in this era where we have novel and targeted therapies, but certainly in the chemotherapy era, highly predictive of poorer responses and poorer durations of response. Trisomy 12, so this is having an extra chromosome 12, and just having a normal karyotype does occur in about 16 to 18% of people, and this is considered to be kind of an intermediate risk. There's no established risk prognosis here. And the second last major group are the patients who have at their diagnosis a deletion 17p. This is about 7 in 100 people. It confers resistance to conventional chemotherapy. It confers suboptimal, but not drastically reduced rates of response and suboptimal durations of response, even to novel therapies compared to people who do not have this mutation. And the last highest risk group are the patients with high complex karyotype. And these are people who have multiple chromosomal changes. And this is the worst predictor, even in the era of novel therapies, of survival and response. And this is, in my view, the most important group to try and identify, and hence the need for conventional cytogenetics and very good microarray assays to be able to tease out those people who are going to be the most vulnerable in their lifetime to this disease. So this figure looks at the chances of your survival from time of diagnosis, looking at the 5 major groups of chromosomal changes, namely deletion 17p, which is the group in the solid black line, which you can see faring worst of all in terms of overall survival from diagnosis, compared to the people out with the 13q who have very long survival over time. In between are the patients with 11q, normal karyotype, and a deletion in their chromosome 12. Looking at it another way, this figure looks at the chances that your disease will progress in the 5 major groups again. So again, in the solid line, you can see that deletion 17p, and this was a study of patients that was done when chemotherapy was the only treatment available, shows a relapsing course where there's really frequent relapses, minimal durations of response to chemotherapy. And you can see this improves out with all the groups, deletion 13q being the most favorable. Complex karyotype had in the year 2000 not been terribly well dissected. And I'll talk about the implications of that in the next slide. So complex karyotype really talks about the abnormalities and genetic complexity in CLL that is quite severe. And we talk about the definition being 5 or more chromosomal structural changes. And this is an independent risk factor for having poor outcomes and poor responses to therapy in CLL. So this was published not so long ago by the Europeans, looking at a very large number of patients, where you can clearly see that patients who have 5 or more aberrations have markedly reduced survival compared to their counterparts who have fewer structural abnormalities. You can see that even in people with deletion 17p dysfunction or TP53 abnormality, and this is to do with an important gene that regulates cell survival and appropriate cell death, that having complex karyotype trumps even this important factor. And this is an important piece of information that your clinician will talk about in terms of maximizing your survival and maximizing your quality of life. So moving on to some examples of what these changes look like, I'll take you to the most common aberration, deletion of the long arm, indicated by the Q, of chromosome 13. There's all of these technical terms, and I'll try and break them down as simply as I can for you today. So mapped out beautifully is the spread of this patient's CLL chromosomes. And we get to chromosome, pardon me, let me go back, to chromosome 13, where you can see here's the short arm, the centromere, the middle part here. And then you can see that the long arm has been cut off here. There's been a loss of material, and an experienced cytogeneticist will be able to visually look at this and recognize this as a deletion 13q. This is an example of a patient with trisomy 12 in their CLL cells. So again, the metaphases are spread here, and you can see not 2, but a third chromosome 12, indicating that there are 3 chromosomes or a trisomy present. And this is another way to demonstrate a trisomy 12 at a third 12th chromosome 12, rather than having your normal 2. And this is by FISH, where a targeted panel of red and green probes are used to determine how many sets of chromosomes there are within this cell. And you can see here that there are 3 green signals coming off rather than the expected 2. And that's how in this cell, trisomy 12 has been defined. Deletion 11q, portending an unfavorable prognosis and related to the ATM deletion, which is encoded in the genetic material in the long arm of chromosome 11, is seen here. So in this spread, you can see here's the short arm, here's the long arm, here's the middle part, the centromere, and this short arm here is cut off. In this slide, what I want to highlight to you is what a deletion 17p using conventional cytogenetics looks like. But it's actually a patient who's far more complex than this. They've got more than 5 abnormalities, and I'll talk you through them briefly. So deletion 17p, P refers to the short arm. 17 is chromosome 17. So here we go to chromosome 17. Here's a short arm, here's the long arm, and there's this middle part, the centromere, and you can see a component of the short arm is missing. And this encodes the TP53 gene, the tumor suppressor gene, the critical gene in terms of being central to appropriate cell survival and cancer proliferation. When this is aberrant, you have disease that is often biologically quite aggressive. It is more common as your disease progresses with therapy, and it confers resistance to chemotherapy, even in the frontline setting. So this is the critical deletion 17p. We can detect this by conventional karyotype, but sometimes when it's more subtle, it can be missed on this, but only seen on FISH testing. In this patient, there is some derivative genetic material, a loss of chromosome 6, a loss of a component of the long arm, chromosome 12, mutations in abnormalities in chromosomes 14 and 15 as well. So this is somebody with an adverse prognosis. Complex karyotype has also been understood in more recent years in a more sophisticated way. We don't just talk about 5 or more structural abnormalities. We talk about them including certain high risk things such as a deletion 17p to be high complex karyotype, because we actually know that there are people who will be identified with complex karyotype who don't have these high risk features such as problems in their chromosome 17 or their chromosome 11, who actually do just as well as favorable risk CLL patients. So that nuance in actually defining the type of complex karyotype is really important. And this is a patient who's got both loss of the ATM gene, as you can see, by loss of this chromosome 11, and loss of chromosome 17, so a deletion in 17p as well. They've got multiple other changes with derivative genetic material, changes in their chromosome 8, their 16, and their 19. That makes them a true high complex karyotype. This is another way to represent that same information in regards to deletion 17p and chromosome 11 changes. So you can see here a single signal of TP53 demonstrating that there's been a loss, a deletion of 17p, and you can see an extra ATM, so an extra component of chromosome 11, which tells us that part of this is going to be some extra chromosome 11 material. So this is the same data reflected in a different way by using a complementary test. Clonal evolution is something that I'll touch on briefly. So we will have genetic changes and chromosomal changes in our CLL cells, often at the outset at the rate of 80%, but that can evolve and you can acquire further genetic mutations, or subclones will be, if you like, selected out and allowed to grow and proliferate and overcome the control conferred by your treatment. So your disease can look more complex over time, and these chromosomal changes and genetic changes can accumulate, making your CLL more genetically unstable and high risk. And this is an example of a patient who began their disease with deletion 13q, as you can see here. And then over time, at their next progression, there was a loss of deletion Q as well. So suddenly a patient had gone from being quite a favorable prognosis to an unfavorable one. And with these changes, inching closer towards that complex karyotype, which is not inevitable, but always in the back of a clinician's mind, because we know how important this is in terms of selecting the right therapy and therefore we're trying to provide the best outcome possible. I'll touch very briefly on molecular testing in CLL, SLL, which is a whole talk in and of itself. I'll be talking about two assays in particular that are important prognostically. The first is IGHV mutational analysis. You can have mutated and unmutated states in the IGH gene of your CLL at the beginning and through the same time over time without evolution. And this can confer different risks depending on whether you're mutated and unmutated. This is a test that is done evaluating the DNA of your CLL cells using polymerase chain reaction assay. It's an assay that requires a lot of genetic material. At the moment, it's done solely at the Peter MacCallum Cancer Centre. The other assay I want to talk to you about is TP53 mutational analysis. This is important because there will be patients who have single DNA-based changes that cannot be detected by FISH testing, that cannot be detected by cytogenetics, yet confers the same adverse prognosis as having a deletion 17p. This test now almost Australia-wide is done through next generation sequencing, where your DNA is evaluated against some probes. We can see mutations in your TP53 gene, present or absent. Along with that, there can be a whole host of other molecular analyses that can be done to finesse your prognosis, look at resistance to therapy. So in the era of chemotherapy, so for example, some of you may have been treated with fludarabine, IGHV, so immunoglobulin gene heavy chain variant, has been tested to look at whether you have a chance of durable long-term remission to chemotherapy. And patients who were in the favorable group were the patients who were actually mutated. People who were in the unmutated group had an unfavorable prognosis. In the era of conventional therapy, that's kind of turned on its head, where there are favorable responses to drugs like ibrutinib, a Bruton's tyrosine kinase inhibitor, if you have an unmutated IGHV state. So this does have predictive value and is useful for all patients prior to their first treatment to have testing done. TP53, as I spoke about earlier, is central in controlling responses to DNA damage and cell cycle. In a normal human cell, when a cell has acquired a lot of genetic injury, then our cell cycle tells that cell to die. So we are not continuing to accumulate nasty damage that can lead to cancer cell formation. In patients with TP53 mutation, that signal for a cell that has become abnormal to die off is lost and it's allowed to proliferate. And this doesn't just exist on its own. It interacts with many other genes involved in cell cycle control, in inflammatory pathways, many other mechanisms in terms of gene mutations that allow cancer cell survival. So while this is central, it's not the one and only gene mutation that can be impactful. The beauty of next generation sequencing is that a lot of these other genes are mapped out in that same test, and your clinician may actually be able to talk to you about finessing your molecular risk. So the good thing about novel therapies, and I'll focus just on ibrutinib today, is that what we knew about responses to therapy in chemotherapy when you had things like TP53 and deletion 17p mutation no longer hold. Patients with these mutations that confer chemo resistance seem to do very well on ibrutinib. So you can have a TP53 mutation or a deletion 17p and be confident that you'll still have excellent progression-free survival and overall survival when you're treated with a novel therapy like ibrutinib. Comparing the risk groups though, outcomes are still less favorable if you have deletion 17p compared to if you are in the more favorable groups, such as deletion 13q. And this is a study showing that upfront, ibrutinib is still effective, even in patients with a deletion 17p or a TP53 mutation when treated with ibrutinib. So coming to the close of this presentation, I wanted to talk about how cytogenetic testing and molecular testing is performed across Australia. The good thing to know is that all Medicare eligible patients can now have cytogenetic testing at any time in their disease. And in my view, this is an important test, in particular to define complex karyotype, and shouldn't be missed while we develop other technologies further. In terms of other testing as a complement involving chromosomal analysis, FISH testing and microarray testing is also Medicare rebatable, with testing funded by our government once every 12 months. Molecular testing in most states is collected in that individual state, but sent to the Peter MacCallum Cancer Centre for IGHV testing in particular. Many states are coming on board, developing their own panels for next generation sequencing. And by the end of the year, molecular testing will also be funded by Medicare, so that there will be no charges for patients at any time when they require testing. So when should cytogenetic and molecular testing be performed in your treatment journey? Everybody prior to starting their first line of therapy should have a chromosomal analysis and molecular evaluation for IGHV mutated or unmutated status assessment and for TP53 mutation. Because CLL is a slowly progressive disease, most clinicians and patients will have plenty of time to see this disease progressing to the point that it needs treatment, and therefore planning can occur so that several months out from treatment start, this kind of prognostication and testing can occur. At each subsequent progression, in particular prior to each next treatment, these tests should be repeated, in particular to look for the other chromosomal and genetic hits that occur, leading to prediction of treatment failure, and importantly, to define complex karyotype. In terms of turnaround and when you can expect your results, FISH results are back within a week. They usually target 4 or 5 abnormalities, but they are often the most critical in terms of prognosis. Cytogenetics, because of the time it takes to grow these cells and the technicalities of analyzing them, can take 3 to 4 weeks, and in some states up to 12 weeks. So you and your clinician should, well in advance of starting treatment, plan and have these tests done. Microarray is a little bit quicker and takes 3 weeks, but it also has some flaws in that it will miss some things that FISH will not. IGHV mutational analysis and TP53 mutational analysis take 4 to 8 weeks. These are often very complex assays, not just in the way the tests are run, but in how they're analysed. So they need sufficient time to be able to get reliable reports, but they can be incredibly important to try and finesse your diagnosis and to help guide clinicians and you to make the best treatment decisions. And that's where I might leave it. Thank you, everyone. We might open the floor to some questions.
Thank you so much for that presentation, Sasanka. It's a very complex subject, and I think that you spoke very well, and the information you provided will be very relevant to everyone watching today. We do, I don't know why I've gone all blurry on my screen, but we do have a few questions in the Q&A. So one is from Margaret, and her question is, when there isn't enough CLL cells circulating in the blood to test on a FISH test, can 17p deletion be detected in a lymph node biopsy, or does a bone marrow biopsy have to be performed?
Thanks. So in patients, you don't really see this with CLL so much, but you might see it with SLL, where there can often be a very minute burden circulating in your blood. And in this instance, sometimes there can be very little in your bone marrow as well. So it may be worthwhile having a look at a lymph node and getting fresh tissue on that to do FISH testing there.
Great. Another question from Alicia. Could you please explain a bit more regarding complex karyotype on initial diagnosis, i.e. before receiving any treatment, with no abnormalities on the FISH? Also, should these tests be redone after treatment?
Yeah. So the first component of that question, talking about complex karyotype and having normal FISH, I suppose complex karyotype is more than just 5 structural abnormalities in your chromosomes. It means 5 chromosomal abnormalities that include a 17p or includes a deletion 11q. There'll be some people, and it's rare to have it up front. It's usually a reflection of having prior heavy therapy, but very rarely we do see it before any treatment at all, in the order of under 5% of people. But you would expect, if you did the complementary FISH test, that you'd see in that patient a problem with their 17p or their 11q. So I don't think you would see a high complex karyotype in someone who had a normal standard FISH panel. The second component of the question, do you mind repeating, Emma?
Yeah, of course. Should these tests be redone after treatment?
Yeah, they should. Not necessarily as a response assessment, but at the next progression. So in terms of response assessment, what you're looking for is how much disease has cleared, rather than expecting it to not only have not cleared, but evolved. So if a progression has been suspected, well, then it's important to look at, well, how much disease is around and what chromosomal mutations have grown, if you like, and what mutations genetically have developed to explain this resistance. It can be important because we look at, especially in the era of novel therapies, resistant mutations that can help to then select what the next treatment and the third treatment should be. And it can also identify that complex karyotype. Does that answer your question, Susan?
I think it was, Alicia. She also has a follow-up question, and then we should have time for a couple more. If someone with complex karyotype has novel treatments, would you expect them to have a more favorable outcome, or would they more likely not reach full/partial remission than someone without a complex karyotype?
So in terms of complex karyotype, broadly speaking, the rates at which patients attain complete remission, partial remission, don't really change. It's the duration of response that's suboptimal compared to someone who doesn't have complex karyotype. So you can still respond, get good disease control, good disease eradication. It doesn't last as long. So the time for you between your next treatment will be significantly shorter than in someone who doesn't have complex karyotype. If you're a young person, for example, a patient under 50 years old with this kind of genetic makeup, the implication can be that your haematologist may actually talk to you about the most intensive treatment that we can offer, which is stem cell transplantation from somebody else. Very, very infrequently done, but it can be important in that particular situation.
We have a question from Peter. So trisomy 12 no established risk assessment. Can you explain this, please?
So we look at favourable and unfavourable groups. Trisomy 12 is something that fits in between. So if you've got normal chromosomes, absolutely nothing that differentiates you, Peter, from your XY status in every other cell in your body, or if you've got this extra chromosome 12 material, it's kind of neither favourable nor unfavourable is really what we understand about it. What we know in terms of clinical behaviour is that it can often have a course that is very slowly progressive, but where the cells under the microscope can actually look far more nasty and angry than your standard CLL patient cells. And often when we see them under the microscope, we often worry that you actually have an aggressive lymphoma. When we look carefully at your cytogenetics, we say, okay, we're reassured this is still CLL, just this, this variant that has this extra chromosome 12.
So some of the questions are quite personal to the individual. So we might get those questions to be diverted to your own clinician and have a conversation with your clinician about some of those specific personal questions. I do have a couple of questions myself. If people watching have CLL and have received treatment in the past without any of this testing, or maybe not all of the recommended tests, do you think it's something they need to discuss with their haematologist before starting their next line of therapy?
Yes, absolutely. It used to be something only accessible in academic centres, but now it's broadly Medicare funded, which is fantastic for access, whether you're a patient in the public or private sector, that you can have your chromosomal aberrations evaluated by cytogenetics, by FISH, by microarray. Soon, molecular testing will similarly be broadly funded, but right now testing is available at no cost to patients. So it's worthwhile getting done because the future of CLL therapy is requiring more and more that you and your clinician have a good handle on these things, because we are trying to be smarter in how we treat our patients and trying to predict best possible outcome, acknowledging that the label CLL is really not enough to define your disease.
Yeah, that was going to be my next question. Is there a lot of clinical trials targeting different genetic mutations or more unfavorable DNA abnormalities?
There's nothing yet that is molecularly targeted. There are clinical trials that are, there is a particular drug called pirtobrutinib, which is the latest generation of Bruton's tyrosine inhibitor. If we think of ibrutinib as its much older cousin, we soon discovered that there will be people within 2 years of treatment with ibrutinib who develop a resistance mutation. So this is CLL that has mutated to bypass the control that ibrutinib has allowed. And this is in the binding site of BTK, the most common being something called C481S being switched out for another protein, leading to a lack of interaction between ibrutinib and that binding site in CLL. And it allows that CLL to then progress and become resistant. The way that pirtobrutinib works is it tries to bypass this site of activity. And so recruiting to this particular trial, there is a group that is looking for patients who come with that C481 mutation to prove, okay, well, we think it's going to overcome this resistance mutation. Does that bear out in a clinical trial? So that's about as far as we've come along in terms of using mutations to pick the right treatment for the right patient. But certainly your clinician will be looking at multiple genetic changes, complex karyotype, as a good reason to encourage you to consider clinical trials, in particular along the lines of immunotherapy, to try and circumvent some of the problems we have in getting really good long-term disease control with chemotherapy and to a lesser extent with novel therapy.
And we'll have time for one last question from Diane. So her question is, if your FISH result is unremarkable, what is causing your CLL, or what's driving your CLL?
Yeah, that's a good question. There will be some people who have completely normal FISH, but does that say that every gene within your CLL is normal, or that the chromosomes are normal? It just says that the targeted panel that we did FISH on is negative. So you most likely don't have an 11q, most likely don't have a 17p, those unfavorable things. Could you still have a complex karyotype? It's possible. Could you have other chromosomal abnormalities that we just didn't target? You're using our FISH probes? You could, and there are others that I haven't spoken about today that we know are drivers towards CLL proliferation. And beyond that, because of the way our DNA is encoded, you can have single point mutations in those long strands of DNA that are completely undetected by chromosomal assays, and where you need molecular testing to see things like a Notch1 being the driver in your particular CLL.
Thank you so much, Sasanka. Oh, just one last question. Sorry, so it should be a quick one. Is ibrutinib only available as second-line treatment in Australia as opposed to first? And this comes from Leanne.
Thanks, Leanne. So there's some good news. Ibrutinib is only available in the relapsed and refractory setting at the moment, but another Bruton's tyrosine inhibitor, a second-generation agent called zanubrutinib, is now available in the first-line setting. So as of now, every single patient in Australia in the first line should not have to be exposed to chemotherapy, where you can have upfront zanubrutinib, or you can have upfront venetoclax and obinutuzumab, depending on, I guess, your risks towards side effects, etc.
Great. They're all the questions we have time for today. I'd like to thank Sasanka again for her incredible presentation. And as I mentioned, it's such a complex topic, and I think you explained it really well. And definitely the images, I think, help to explain such a complex topic. So thank you so much for coming online with us today, especially on a weekend. And thank you everyone else who joined the webinar today and those who filled out the pre-education survey. As I mentioned, there will be a post-education survey which will be sent out in the coming weeks. And if you do have a chance to fill that out, we'd really appreciate your time. So thank you so much, everyone, for today, and enjoy the rest of your weekend.